Every drug tells a story. Some drugs walk up to a receptor, bind to it, and shout, triggering a response. Those are agonists. But today, we're talking about the drugs that do the opposite. The ones that show up, take the seat, and say, nothing. Welcome to the complete guide on antagonists in pharmacology. By the end of this video, you'll understand exactly what antagonists are, how they're classified, the molecular mechanisms they use, their key features, their clinical advantages, and their limitations. This is everything you need, from the textbook to the bedside. Let's get into it. An antagonist is a drug or ligand that binds to a receptor and blocks activation by an agonist, preventing a biological response. Unlike agonists, antagonists block rather than initiate cellular effects. Two properties define every antagonist. First, affinity. Antagonists have high affinity. They bind strongly to the receptor. We measure this with the dissociation constant Kd. The lower the Kd, the higher the affinity. High affinity ensures the antagonist can effectively compete with endogenous ligands, even at low concentrations. Second, intrinsic activity, or efficacy. Antagonists have zero intrinsic activity. They possess affinity, they bind, but they do not trigger a conformational change that leads to a response. They are silent occupants. This combination, high affinity, zero efficacy, is the pharmacological fingerprint of a pure antagonist. Let's begin the classification of antagonists by focusing on the most fundamental approach. Classification by site specificity, starting with orthosteric antagonism. Orthosteric antagonism is the most straightforward mechanism. These antagonists bind directly to the active site, the same spot where the endogenous ligand normally sits. The antagonist and agonist are in direct competition. Whoever is present at a higher concentration and has a higher affinity wins the receptor. So, how do we actually measure how strong an antagonist is? Not just observe it, but quantify it precisely. That's where the Shield equation comes in. In competitive, or orthosteric antagonism, the antagonist and agonist are basically competing for the same spot on the receptor. So, if you add more antagonist, it becomes harder for the agonist to produce the same effect. What you'll see experimentally is this. The dose-response curve shifts to the right, but the maximum effect stays the same. To measure this shift, we use something called the dose ratio. In simple terms, the dose ratio compares the EC50 in the presence of an antagonist to the EC50 without it. So it tells us how much extra agonist is needed to get the same response. The bigger the dose ratio, the stronger the blocking effect. Now, mathematically, this relationship can be described like this. The dose ratio equals 1 plus the antagonist concentration divided by Kb. Here, Kb represents how tightly the antagonist binds to the receptor. If we rearrange that, we get dose ratio minus 1 equals antagonist concentration divided by Kb. Now here's the key step. We take the logarithm of both sides. And this gives us the Shield equation. So now it becomes log of dose ratio minus 1 equals log of antagonist concentration minus log of Kb. Why is this useful? Because this form gives us a straight line when we plot it. That's called the Shield plot. If the slope of that line is close to 1, it confirms that we're dealing with true competitive antagonism. And from this same plot, we get an important value called Pa2. Pa2 is simply the negative log of Kb, and it tells us how potent the antagonist is. So, a higher Pa2 means a stronger antagonist, because you need less drug to block the receptor. And that's the power of the Shield equation. It doesn't just measure antagonist strength, it actually confirms the mechanism as well. Most classical drugs are orthosteric antagonists. Examples include beta blockers, which compete with adrenaline, H1 antihistamines, which compete with histamine, ACE inhibitors, which block the active site of the angiotensin-converting enzyme. Second is allosteric antagonism. Allosteric antagonism is more nuanced because the allosteric antagonist does not directly block the agonist's binding site. Instead, these antagonists bind to a topographically distinct site, a location on the receptor that is physically separate from where the agonist binds. By occupying this allosteric site, the antagonist induces a conformational change, a shape change, in the receptor protein. This reduces the agonist's affinity or efficacy. Critically, increasing the agonist concentration does not overcome this blockade. The lock itself has been warped. These are also called negative allosteric modulators, NUMs. Positive allosteric modulators, PAMs, do the opposite. They enhance agonist binding or efficacy. Benzodiazepines, for example, are PAMs at the GABA A receptor. The same allosteric site can be exploited in both directions, to amplify or suppress receptor activity. Two major advantages of allosteric antagonists. First, drug design selectivity. Allosteric sites are often unique to specific receptor subtypes, making allosteric drugs highly selective with fewer off-target effects. Second, saturable effect, sealing. Once all allosteric sites are occupied, additional drug produces no further change. This provides an inherent safety margin. Real-world example, Maraviroc, an HIV drug, is an allosteric antagonist at the CCR5 co-receptor on human immune cells, preventing HIV from docking and entering the cell. Now let's classify by how antagonists bind, specifically whether their blockade can be overcome. Here comes competitive, reversible antagonists. These are the most common drugs in clinical practice. They compete with agonists for the same binding site, the orthosteric site. The competition is dynamic and concentration dependent. Both the agonist and the antagonist are constantly binding and unbinding to the receptor, and the outcome at any given moment depends on the ratio of their concentrations and their respective affinities. Their effect is surmountable. It can be overcome by increasing the agonist concentration. This is the defining feature of competitive, reversible antagonism. The pharmacological fingerprint on the dose-response curve. Parallel rightward shift. The curve moves to the right but keeps its shape. EC50 increases. More agonist is needed to achieve the same 50% maximal effect, because the antagonist is occupying some receptors. Emax unchanged. The maximum possible response is preserved, because with enough agonist, all antagonist molecules can be displaced. This shift is tested and quantified using the Child plot. In an emergency, say a patient on beta blockers who needs urgent cardiac stimulation, administering a high-dose agonist can partially overcome the blockade. However, this also means that if the body produces large amounts of endogenous agonist, like adrenaline during extreme stress, the drug's effect may be temporarily reduced. Examples: propranolol, beta blocker, competes with adrenaline at beta receptors. In a stressful situation, your body can sometimes overcome the block by pumping out more adrenaline. Naloxone, Narcan, competes with opioids at mu receptors. Because it's competitive, it can displace heroin or morphine to reverse an overdose almost instantly. Atropine competes with acetylcholine at muscarinic receptors to increase heart rate or dilate pupils. Next is the competitive irreversible antagonism. It is also known as insurmountable antagonism, which occurs when an antagonist binds to the same orthosteric active site on a receptor as the agonist, but forms a covalent bond that cannot be broken under physiological conditions. Unlike reversible competitive antagonists, which have affinity but no efficacy and can be displaced by increasing the concentration of an agonist, irreversible antagonists create a permanent receptor-antagonist complex, rendering the receptor non-functional for the rest of its lifespan. As a result, the receptor remains inactive until it is degraded and replaced by newly synthesized receptors, meaning that the duration of action depends on receptor turnover rather than drug elimination. Because this binding cannot be overcome by adding more agonist, the antagonism is described as insurmountable, and its key pharmacological effect is a reduction in the maximal response, or Emax. The extent of this reduction depends on the presence of spare receptors. At low concentrations of the antagonist, the remaining unblocked receptors may still be sufficient to produce a full response, but as more receptors are irreversibly blocked and the receptor reserve is depleted, the maximal response progressively decreases. Classic examples of competitive irreversible antagonists include phenoxybenzamine, which forms a covalent bond with A-adrenergic receptors, and aspirin, which irreversibly inhibits the cyclooxygenase enzyme. Now we are moving to non-competitive antagonism. In that first one, reversible non-competitive antagonism, it is a bit different from what we've seen so far. Instead of competing with the agonist for the same active site, this type of antagonist binds to a completely different location on the receptor, known as an allosteric site. Now, because it's binding somewhere else, it doesn't block the agonist from attaching to the receptor. Instead, it changes the shape of the receptor, a conformational change, which reduces the receptor's ability to respond. So even if the agonist binds, the response is weaker. An important point here is that this interaction is reversible. The antagonist binds via non-covalent interactions, meaning it can detach from the receptor. Once it's removed, the receptor can return to normal function. Since the antagonist is not competing for the same binding site, increasing the concentration of the agonist doesn't overcome its effect. No matter how much agonist you add, the receptor's response is still reduced. This leads to a key pharmacological feature, a decrease in the maximum response, or Emax. On a dose-response curve, instead of shifting to the right, the curve is pushed downward. The peak effect is lower, even though the agonist is still present. The EC50 may stay the same, or show only minor changes. Unlike irreversible antagonists, the receptor itself is not permanently damaged or inactivated. There's no need for new receptor synthesis. Once the antagonist is removed, normal receptor activity can recover. Classic examples of this type of antagonism include drugs like ketamine and memantine, which act on NMDA receptors. They bind allosterically and reversibly, reducing receptor activity without directly blocking the agonist binding site. Now, let's move to irreversible non-competitive antagonism. It refers to a type of drug action in which an antagonist binds permanently to a receptor and blocks its function, regardless of the amount of agonist present. This binding is usually covalent, meaning the antagonist attaches very strongly and does not dissociate from the receptor. As a result, the receptor becomes permanently inactivated. As a result, increasing the concentration of an agonist cannot overcome the blockade. No matter how much agonist you add, the response cannot reach its original maximum. The most important effect of irreversible non-competitive antagonism is a decrease in the maximum response, also known as Emax. This happens because the total number of functional receptors is reduced. Initially, the EC50 may remain unchanged due to the presence of spare receptors. However, as more receptors become inactivated, the response progressively declines. Recovery from this type of antagonism depends on the synthesis of new receptors, not on the elimination of the drug. Therefore, the duration of action is often prolonged. Mechanistically, the antagonist may bind either to the active site or to an allosteric site that alters receptor function. In both cases, the outcome is loss of receptor activity. A classic example is phenoxybenzamine, which irreversibly blocks alpha-adrenergic receptors and is used in conditions like pheochromocytoma. Moving beyond receptor antagonism, some antagonists act through specialized, non-receptor mechanisms. Under the specialized types, first, we have chemical antagonism. It is the basis of many antidote strategies in toxicology. The antagonist doesn't interact with any receptor. It simply neutralizes the offending molecule before it can even reach its target. The interaction is stoichiometric, meaning that dosing must be carefully calculated to ensure enough antagonist is administered to neutralize the threat. Examples: protamine sulfate, a positively charged protein that binds to heparin, which is highly negatively charged. They neutralize each other directly in the blood, before any receptor is involved. Dimercaprol, a chelator for heavy metals. It binds toxic metals like arsenic or mercury and allows them to be excreted. Antacids, the bases that chemically neutralize stomach acid, hydrochloric acid, to raise gastric pH. And activated charcoal, that binds drugs in the GI tract, preventing their absorption after ingestion. Next is physiological or functional antagonism. Here, two agonists act on different receptors to produce opposite physiological effects in the same tissue. Neither drug blocks the other's receptor. Instead, they produce opposing downstream effects that cancel each other out at the level of the organ or system. Why it matters clinically. Physiological antagonism is the basis of many emergency treatments. When a receptor-specific antidote is unavailable, a drug that produces the opposite physiological effect can be life-saving. Important distinction. Unlike competitive antagonism, physiological antagonism cannot be quantified using simple receptor pharmacological tools, such as the Child plot. The interaction is complex and tissue-dependent. Examples: epinephrine versus histamine. In anaphylaxis, histamine causes dangerous bronchoconstriction. Epinephrine doesn't block histamine receptors. It binds beta-2 receptors to cause bronchodilation, fighting the effect via an opposing pathway. Glucagon versus insulin. Insulin lowers blood sugar via the GLUT4 pathway. Glucagon raises it via gluconeogenesis. They antagonize each other's effects, not their specific receptors. Moving to pharmacokinetic antagonism. There is no interaction at the receptor level in pharmacokinetic antagonism. Instead, one drug reduces the effective concentration of another by altering its ADME profile. Absorption, distribution, metabolism, or excretion. Clinical importance. Pharmacokinetic interactions are a leading cause of adverse drug reactions and treatment failures. Understanding CYP450 enzyme induction and inhibition is essential for safe prescribing. The four subtypes. Absorption. One drug prevents another from being absorbed from the gut. Activated charcoal binds drugs in the GI tract, preventing their absorption after poisoning. Cholestyramine binds bile acids and co-administered drugs, reducing their uptake. Distribution. One drug displaces another from plasma protein binding, altering its free active concentration. This can suddenly increase the effective dose of the displaced drug, causing toxicity. Metabolism. One drug induces or inhibits liver, CYP450 enzymes, changing the rate at which another drug is broken down. St. John's wort induces CYP3A4, speeding up the metabolism of drugs like cyclosporin, an immunosuppressant, causing the body to clear it too fast for it to work. This has led to organ rejection in transplant patients. Excretion. One drug alters urinary pH or competes with another for renal transporters, thereby altering how quickly the other drug is excreted from the body. Coming to classification D. Partial agonists as antagonists. A partial agonist occupies the same receptor as a full agonist, but produces a smaller conformational change. It only partially activates the receptor. When both are present, the partial agonist displaces the full agonist from some receptors and reduces the response. It acts as a buffer or functional antagonist against the stronger agonist. The same drug can be either an agonist or an antagonist depending on context. In the absence of a full agonist, for example, in an opioid-naive patient, buprenorphine acts as an agonist, providing pain relief. In the presence of a full agonist, for example, in a patient actively using heroin, buprenorphine competes and reduces the effect of heroin, acting as a functional antagonist. Ceiling effect. Partial agonists have a ceiling on their maximal response, a built-in safety feature. Buprenorphine causes less respiratory depression than full opioid agonists like morphine, even at high doses. This is why it's used safely in opioid dependency treatment. More examples. Varenicline, Chantix. A partial agonist at nicotinic receptors. If you smoke, it blocks the rush from nicotine. the antagonist effect, while providing a tiny bit of stimulation to prevent withdrawal, the agonist effect. Dual action in one molecule. Aripiprazole, Abilify, called a dopamine stabilizer. In areas of the brain with too much dopamine, causing psychosis, it acts as an antagonist. In areas with too little dopamine, it acts as an agonist. This context-dependent behavior makes it uniquely useful in psychiatry. Finally, we have mixed agonist-antagonists that show both agonist and antagonist effects simultaneously, but at different receptor subtypes. This is distinct from partial agonism. Here, the drug is a full agonist at one receptor type and a full or partial antagonist at another. The key to understanding these drugs is receptor subtype selectivity. Clinical advantage. By combining agonism for therapeutic effect and antagonism to block unwanted effects, these drugs can be designed with built-in safety features, providing analgesia while limiting euphoria and addiction potential. Pentazocine acts as an agonist at kappa receptors to provide pain relief, but as an antagonist at mu receptors, preventing the high or respiratory depression typically seen with morphine. Critical clinical warning. Precipitation of withdrawal. In opioid-dependent patients, giving a mixed agonist-antagonist like pentazocine or nalbuphine can suddenly displace the full agonist from mu receptors and precipitate acute withdrawal syndrome. This is a dangerous and painful reaction that must always be anticipated before prescribing. Now let's consolidate the key features that define all antagonists. 1. Zero intrinsic activity. Antagonists do not initiate a biological response upon binding. Their presence is only noticed when an agonist tries to bind. In the absence of any agonist, a pure or neutral antagonist has no observable pharmacological effect on its own. It is pharmacologically silent. 2. No basal change. A neutral antagonist does not change the basal activity of a receptor. It only prevents further activation. This is an important distinction from inverse agonists, which we'll come to shortly. Receptor blockade. Their primary action is to prevent the binding of endogenous ligands, like hormones or neurotransmitters, or exogenous agonists. This blockade is the therapeutic cornerstone in many diseases. For example, blocking excessive noradrenaline at beta receptors in heart failure reduces cardiac workload. Blocking histamine at H1 receptors prevents allergic symptoms. The degree of blockade depends on the antagonist's concentration and its affinity relative to the agonist. Affinity and competition. Orthosteric antagonists directly compete with the agonist. The outcome depends on relative concentrations and affinities of both molecules. Allosteric antagonists, by contrast, work indirectly by changing the receptor's shape, making it harder for the agonist to bind or produce a response, even without direct competition. Finally, reversibility. Reversible antagonists form weak, non-covalent bonds, hydrogen bonds, van der Waals forces, or ionic interactions, allowing the drug to detach when conditions change. Irreversible antagonists form strong covalent bonds, permanently disabling the receptor until the cell synthesizes a new one. This distinction has major clinical implications. Reversible antagonism is titratable and safer in overdose, while irreversible antagonism provides prolonged action but is harder to manage if side effects occur. Let's now go through the 4 molecular mechanisms antagonists use to block receptor activity. Mechanism 1. Steric hindrance. The antagonist simply occupies the binding pocket, preventing the agonist from entering. This is the most straightforward mechanism. The antagonist physically blocks access to the binding site due to its bulk and shape. Think of steric hindrance like a car parked in a space. No other car can park there until it leaves. Example: atropine occupies muscarinic receptors, preventing acetylcholine from binding. This is why atropine causes dry mouth, dilated pupils, increased heart rate, and urinary retention, all effects of blocking acetylcholine's normal actions. Mechanism 2. Conformational lock. Here, the antagonist binds to the receptor in its inactive state, preventing it from transitioning to the active state. This goes beyond simple blockade. The antagonist actively stabilizes the receptor in a non-functional conformation. This is the mechanism of inverse agonists. A neutral antagonist just blocks the door. An inverse agonist locks the receptor shut. Why does this matter? In diseases driven by constitutively active receptors, receptors that are spontaneously active even in the absence of an agonist, such as in certain cancers or hyperthyroidism, a neutral antagonist is insufficient. An inverse agonist is needed to actively suppress that basal activity. Example: propranolol stabilizes the beta-adrenergic receptor in its inactive conformation. In conditions where receptors are constitutively active, this mechanism reduces basal signaling back to normal levels. Mechanism 3. Allosteric modulation. The antagonist binds at a site remote from the active site, but the conformational change it induces ripples through the receptor, altering the agonist binding pocket from a distance. Allosteric modulation is like adjusting a lock's internal mechanism from a side panel. You never touch the keyhole, but you make it harder for the key to work. Example: benzodiazepine inverse agonists, such as beta-carbolines, bind allosterically to the GABA-A receptor, reducing GABA's action. This is the opposite of classic benzodiazepines like diazepam, which are positive allosteric modulators. Drug design. Advantage. Because allosteric sites are often unique to specific receptor subtypes, drugs targeting them tend to be more selective and have fewer off-target side effects. Mechanism 4. Covalent bonding. The antagonist creates a permanent chemical bond with the receptor, destroying its utility until the cell synthesizes a new one. The drug essentially becomes part of the receptor protein. Critically, the duration of covalent antagonism is not determined by the drug's plasma half-life, which may be short, but by how fast the body replaces the blocked receptors or enzymes. This is why a single low dose of aspirin has such a long antiplatelet effect. Platelets cannot make new COX-1, so the block lasts their entire 7 to 10 day lifespan. Example: phenoxybenzamine irreversibly blocks alpha-adrenergic receptors. Even massive adrenaline surges from a pheochromocytoma cannot overcome the block. Why are antagonists so valuable in medicine? Here's a summary of their key advantages. Targeted blockade. They specifically inhibit overactive pathological pathways, for example, beta blockers for hypertension or heart failure. Safety profile. Because they lack intrinsic activity, they are generally inert in the absence of an agonist, reducing the risk of overstimulation. Emergency utility. They are essential as antidotes: naloxone for opioid overdose, protamine for heparin reversal. Predictable dynamics. Their effects can be accurately quantified using dose-response relationships, EC50 and PA2 values. Reduced tolerance. Unlike agonists, pure antagonists are less likely to cause receptor downregulation. Reversibility and dose titrability. Competitive antagonists can be carefully titrated to achieve the desired level of blockade, and the effect can be reversed if needed. Broad clinical applicability. Antagonists are used across virtually every medical specialty: cardiology, psychiatry, immunology, anesthesia, oncology, and more. But antagonists are not without their drawbacks. Here are the key limitations, starting with loss of normal physiology. Blocking a receptor doesn't just suppress pathological signals, it can also block necessary endogenous signals. For example, beta blockers can cause bradycardia by blocking beta-adrenergic receptors that normally maintain a normal heart rate. Receptor upregulation and rebound. Chronic blockade leads the body to increase the number of receptors, a process called supersensitivity. Abrupt withdrawal can then cause dangerous rebound effects, such as rebound hypertension when stopping antihypertensives suddenly. Irreversibility risks. The effects of covalently bonding drugs are hard to reverse in overdose scenarios, since recovery depends on receptor turnover, not drug elimination. Off-target effects. Non-selective antagonists can cause side effects in other tissues. For example, non-selective beta blockers block beta-2 receptors in the lungs, causing bronchospasm, which is dangerous in asthmatic patients. Agonist dependence. Antagonists have no therapeutic benefit if the target agonist is absent or inactive. They are reactive, not proactive, drugs. Constitutively active receptors. In diseases where receptors are spontaneously active, certain cancers and psychiatric conditions, a neutral antagonist is insufficient. An inverse agonist is required to suppress the basal activity. This is an emerging and important consideration in drug design. Partial agonist complexity. Drugs like buprenorphine behave differently depending on the patient, acting as an agonist in opioid-naive patients and as an antagonist in opioid-dependent patients. This tissue-dependent behavior requires careful clinical assessment before prescribing. And finally, drug interactions. Antagonists can be involved in complex drug interactions. For example, rifampicin inducing CYP450 enzymes and reducing antagonist plasma levels, naloxone precipitating withdrawal in dependent patients, or CYP450 inhibitors causing antagonist toxicity. Antagonists are everywhere in medicine, from the beta blocker protecting a failing heart, to naloxone saving a life in the emergency room, to maraviric blocking HIV at the cell membrane. Understanding them deeply is what separates a good prescriber from a great one. Thanks for watching. If this video helped you, smash that like button. It genuinely helps this channel grow. Subscribe if you haven't already, and hit the bell so you don't miss the next video. See you in the next one.